I'm sending that to, there we go. You'll do your part on the end. This is our opportunity each time we come together through the education, awareness, and empower to reestablish our own trust in the healthcare system and what we're doing through our understanding of individual topics related to our health. Today, we're going to have a conversation about hypertension. I'm going to come right back to that because we have a very special guest on here with us today, and I'm going to introduce her. But before you know what we do, we have housekeeping. The first thing is, I hope by a show of hands, each of you has been going back to our Everyday Health web link. If you have, put the reactions up and show your hands if you've been going. If you haven't, you've got homework to do. All right, Mark's hand is up. Who do I see? Okay, I see some hands. All right, Clay's going. Who else? Crystal, you haven't been out there? All right, we'll make sure everybody gets out there and goes to our own site at BAAHRI as well. So the next thing for homecoming is you should now be receiving our communications through MailChimp and or a direct email that says BAAHRI.org. Thank you for opening those, clicking on those, and making sure that you're able now to receive our information. I have a special person to introduce. Japs, if you will come off camera, on camera, so we can see you. BAAHRI is happy to introduce our event coordinator. So we're moving up in the world. This is Japs Logston. She will be sending out surveys. She'll be sending out our invites, and she'll be communicating resources that we have to share. So Japs, welcome, and everybody give her a high five and a hello and welcome her to the team.
Hello, everybody. Nice to meet you. Thank you.
Very good. Thank you, Japs. So from today, we will post the recording on the site on BAAHRI.org. We will also make sure that you have a new resource. That resource is a website, healthline.org. And guess what? Our own contributor today, Dr. Bayo Curry-Winchell, and we're going to call her Dr. BCW, and I'll give her an introduction. She is an actual contributor to healthline.org. You know how we want to have trusted partners. We want to have credible information. Our speaker today is one of those over 100 who contribute to that site. You'll see this site, we'll send it out to you, is an African-American focused site. So you've got everyday healthcare, and now you'll have Healthline. So with that, I'd like to take a moment and introduce to you, many of you may know her, but Mark was perusing the health equity information out there and came across a TED Talk as well as Twitter, Instagram that actually features Dr. BCW. And Dr. BCW is the medical director of community engagement and health equity. And she's in Reno, Nevada. And what you will find is she co-leads diversity, equity, and inclusion, belonging, and is the medical director at the urgent care clinics at Carbon Health and St. Mary's Regional Medical Center in Reno, Nevada. There's so much that I can say about her. Twitter, LinkedIn, Instagram, TikTok. She is a social media queen. She wants us to have access to great information about healthcare that we can trust. So she is a valued and trusted partner. The one TED Talk that I'd like for you to think about going out to see is the one that says ensuring equitable quality treatment of the pain in Black and marginalized people. Hear that again, ensuring equitable quality treatment of pain in Black and marginalized people. That was done on November the 10th, 2020, her TED Talk. So I think is that the right title? Is that right? No, that's not the title. Come off mute and tell me the right title.
It's Why Don't Blacks Trust the Healthcare System?
There you go.
And it
Okay.
was released in October. So if
Okay.
you put Bayo Curry-Winchell in there, it's titled Why Don't Blacks Trust the Healthcare System? And I'll try to put a link in at the end in the chat.
Okay. Perfect. So we're excited. You know what we do on these calls is just have conversations. So tonight, our conversation is going to be about hypertension. When you think about the 11 most common conditions that disproportionately affect Black people, hypertension is one of those. So this is a topic or an area that Dr. BCW is going to speak with us about right now. Thank you so much for joining us, and welcome.
Thank you, Lisa, and thank you, Mark, for having me. And it is a pleasure just to be here in front of everyone and share information. So as Lisa mentioned, my first name is Bayo, and my last name is quite long, Curry-Winchell, but I go by Dr. BCW. But sometimes I also like to kind of break it apart. So often, because I'm a family medicine doctor, an urgent care doctor, as well as I subspecialize in child abuse and sexual assault. So I'm a medical director for the county. My pediatric patients often call me Curry like the spice. I don't know if anyone is an avid cooker or a chef here, or Winchell. There's actually a donut company on the West Coast. I don't know if it's on the East Coast, called Winchell's Donuts. So, he's shaking his head. Well, I'm known here as Dr. Spicy Donut. And so it brings me so much joy, and it's quite fitting because I'm a blend of things. I am not a traditionalist by any means. This energy, even at 2 a.m., this is who I am. And I love what I get to do as a physician. I'm also a mom. I've got 2 little girls. I've got a 6-year-old and an 8-year-old who keep me on my toes and call me out on all of my deficiencies, even ones I didn't realize I didn't have. So that's always been a joy. And most importantly, I'm a practicing physician. And I like to highlight that point because often you hear doctors out there talking about things and sharing health information, but they're often missing that lived experience. And so I'm a practicing physician who sees all ages, including abuse and neglect. And so let's get to it. So my love is really highlighting inequities and disparities and showcasing what is happening in healthcare to this day. And it's impacting Black lives every single day. And so when I think about why I became a doctor, and yes, we often hear this, was to help people. Well, when I had my journey through med school, I kept finding these deficiencies or these race-based practices that were really focused on giving care to specific groups based on the color of your skin. And when I looked at that, and then I also saw how it was affecting my family, and I'll share with you, my dad, he just recently passed away, 99-year-old World War II Korean and Vietnam War veteran, who passed away in August. I remember seeing how he was treated when he would seek care in the VA or even outside the clinic. And then I would also hear the providers state, oh, we're giving this medication to you based on the fact that you're Black or African American. And it wasn't until I went to med school that I was like, well, why the heck is this happening? I didn't understand. And so my dad always told me to go back to the core of things, and then you build, and then you can understand. And so when I was looking at certain practices, such as high blood pressure, I saw these really alarming statistics that we all know. I know that Blacks are considered at the highest risk for developing hypertension. I also knew that we were dying at a disproportionately higher rate of kidney disease. And then I also knew that often we are waiting on the transplant list to get a kidney. And when you put all of those things together, when you look at how do you develop hypertension, it has to do with the kidneys. But then if your blood pressure isn't controlled, then you develop kidney disease. And then you may need a kidney transplant list, be on the kidney transplant list. So when I put all those pieces together, and then I saw that the current practice to this day is there are certain classes of medication that are offered to Black patients for your blood pressure. And so I'm going to have you take a step back when I say that I'm going to give some definitions. So I just mentioned that if you are Black, there are two classes of medications that are offered to you. Now, some people would say, yes, that makes sense because we're at a disproportionately higher rate of disease. Well, I'm going to ask everyone to think about this. Being Black is my race, and it's defined as a social construct. But that is not biological and it's not genetic. And so why are we delivering care based on the color of someone's skin? And then I thought, let's go a little bit deeper. When I look at the anatomy of what a Black person has, a person who's not Black, and I just look at the kidneys, I know Black kidneys and white kidneys are exactly the same. And so then I'm thinking again, why are we delivering this care? And then I started to observe how certain patients weren't doing well on specific medicines that were offered to them based on the color of their skin, and how if they possibly were offered all of the medications, maybe they could have actually had their blood pressure controlled sooner, which means they wouldn't have the possibility of developing kidney disease or waiting on the transplant list. And then I'm going to build even more. When you look at the statistics right now, 31,000 Black Americans are diagnosed with chronic kidney disease per month. And then we also have a huge number of patients waiting for kidneys. And when you look at from the beginning or the start of care, that we are put at a disadvantage based on the color of our skin, how are we supposed to make that equitable leap? How are we supposed to be able to have that care? And so that's where I kind of like to always talk about that full access. People often say inequities and disparities are rooted in access to care. Yes, access is important, but if I access the care and you are going to give me different care based on the color of my skin, that's a problem. And I always like to give an example of this because I remember when I started to share this information, I would say, just because I'm Black doesn't mean I'm African. So let's uncouple that piece. Not only are you delivering care based on the color of my skin, you're assuming that I'm a specific ethnicity. And yes, specific diseases, diabetes, hypertension can be related to family history, ethnicity, but you need to get that right on what part is that ethnicity and not just parrot based on the color of someone's skin. And that's where my love and drive is to really highlight these race-based practices that everyone should know about. And so through that, I've been able to create a free series that is out there for anyone to consume. And I do it in bite-sized formats. And that's what Mark saw. It's like 1 minute and 30 seconds. And I talk about high blood pressure and how right now, based on the color of your skin, you're offered 2 medications. And so in that video, I highlight studies because I'm also acutely aware that even though I'm a board certified physician, I still have to prove myself. And then I have to prove myself even more as a Black female physician, just based on those biases and other factors that come along. And so in those videos, I have my studies that show, a recent study showed by UCSF that race-based practice of high blood pressure shows no benefit. And I'll put that link in the study. So my goal by sharing this information is in hope that you not only advocate and use this for yourself, but also your family and your loved ones, because the more you know, the more you can advocate. Because we always hear, how can I advocate for my best care? Well, it's all about knowing what care you deserve to have. And right now, this type of delivery is happening every day. And so I'm going to stop right there just to see if there's any questions, because again, it's about a conversation and that's what's important to me. And then I can sprinkle in more information as well.
This isn't a shy group, so I know somebody's got something that they want to ask or to say. That was a great way to summarize what inequity looks like and what race is not scientifically in terms of the way that we are treated. So I think that that was very clear for this group, and going forward, we have a better understanding when we're looking in the face of our clinicians and saying, how are you making these decisions and with the treatments we're given. So any
Absolutely.
questions?
And Lisa, I do put it, you've seen that video at the end. I encourage everyone to ask your provider, why did you choose this medicine? Or are you practicing race-based medicine? And just put it out there so you know what situation you are in.
Mm-hmm. I'll put a poll out there. I don't have the poll. This is safe space. We can talk about what medicines we're on. We can talk about what we have. But if you're on a hypertensive medication, why don't you put it in the chat which one you might be on?
And Lisa, may I add one more thing that I wanted to mention in that full circle? So when we talk about high blood pressure and we talk about kidney disease, there's another layer that is at the start that is also putting us at a disadvantage. And so it's called GFR, or glomerular filtration rate, but GFR. And so this test is a blood test that is used to assess how healthy your kidneys are. Now, there's a differentiator, though, unfortunately, that says Black versus non-Black. So when you get your blood work done, they put one, if you're Black, in one category and everybody else in a different category. So the reason why that's a problem is there was this thought back in the day that Black people, our kidneys were healthier than non-Black patients. And that was based on the fact that we were considered muscular, more like just of a different type, as well as there's a byproduct. So you've got your kidneys and there's this byproduct called creatinine. And if your creatinine is too high, that can increase your risk for kidney disease. So this test, the GFR, is splitting Black versus non-Black. So the problem with that is if I go in and I get my blood drawn to see if I have kidney disease, and somebody who is non-Black does the same thing, my kidneys will be considered healthier than someone else. The problem is I could actually have kidney disease right now, but because of my race, I am considered not to have kidney disease. 5, 10 years later, when I hit that threshold that they have decided based on the color of my skin, I have now developed stage 3 chronic kidney disease when I had it years ago. So that's another step or another piece of the puzzle when we talk about Black people at dying at a disproportionately higher rate of disease from kidney disease. So that's an important piece that I want everybody to know.
We have a couple of comments in the chat. One brave soul put in the treatment that they're receiving. And so is the bisopropyl. Is that right? Did I say that right? Hydrochlorothiazide. Is that?
So there are two classes of medicine right now for high blood pressure. And so when I say classes, there's actually several medicines that fall under that class. And so the thiazides, hydrochlorothiazide, is one of those. And then you've got calcium channel blockers such as amlodipine, all of those words. And so it's important when I say those classes to look and see whatever medicine you're on, if it falls into those two categories. I'm going to right now put that study in the link, just so you guys have it right away. So you can even see more of the medicines that I'm referring to. So that way you have it right away. I don't want it to be delayed.
Okay. And while she's putting that in the chat, thank you. We have two other questions in the chat. One is, if someone's receiving cancer treatments, how does it impact or affect their blood pressure, is what they're asking.
So it can affect, of course, it's hard for me to say specifics because I'm not sure, what type of cancer med treatment you're on. But as we know with chemotherapy or cancer treatment, it's a way to either temper or kill those cancer cells. And so all of those things take a toll on all of your organs, your healthy cells and so forth. And that can include your kidneys. And so if this medication is released or broken down by your liver, your kidneys, primarily your kidneys when we talk about blood pressure, that can overall affect your blood pressure. Another good example is, when we eat sodium and all the food that we're eating, that also is helpful for our overall blood pressure. When you're on a cancer or when you're receiving chemotherapy, often a side effect is you're nauseous, you're not eating as much, you may not be drinking as much. So that can also be and also have some impact on your overall level or range of blood pressure.
Great response. I have another question related to cancer. What about radiation? Radiation treatments.
So that can as well. Of course, it depends upon where that radiation is really localized to based on whatever diagnosis you have. But that can affect your blood pressure as well, whether it's high or low. And sometimes we forget low blood pressure as well as is as dangerous as high blood pressure. So we often forget being too low means that you're not able to get the blood to go through all the organs, your brain, all those things that you need it to get to when your blood pressure is too low.
Okay. Mark has something he wanted to say. I see your hand.
Thank you. Can you all hear me this way?
Mm-hmm.
Good to virtually or see everybody, or at least see your names. I wanted to ask everybody, and as you know, I try to stay out of it largely, but obviously I can get very excited and very motivated by information that really speaks to us. And I'm curious to know that if everybody would feel comfortable coming off mute and really engaging and answering this question. How do you feel about what you're hearing? What is the concept, or how do you perceive what Dr. BCW is sharing, and how does that make you feel? Or do you have questions to further understand what the suggestion might be here? Do we feel like we follow, or is there any threat to you, or is there an issue what she's described thus far? Or how do you feel, or how do you interpret what you've heard? Anybody?
Crystal, I'm going to call on you because you had a great comment in the chat where you said, I had never thought about challenging physicians making decisions based on my race. That's very interesting. So do you want to elaborate on that, Crystal?
I don't know what more to say other than it's very mind-boggling there. And just the way you explain that, and then the difference. I also made a comment. I love that you clarify the difference between race-based medicine versus diseases that affect our community, because we often think about the diseases and people talk about the diseases that affect us, but never really thought about there being different treatments for different groups of people, and we all still have the same parts, you know.
And often when I give this talk, and I didn't share this with Lisa and Mark, there is silence because it's uncomfortable what I'm sharing. So this is actually normal what I see, and it's good because it's shocking, it's alarming, and you have to kind of now reprocess all of those things because it really shines a light on a new, it's a new perspective to think about it from this level. And when I did the TED Talk, and I'll put it in there, I received a lot of some backlash, from some providers who were like, no, we're doing the right thing. But every time, even after they heard my talk, and I said, my race is not, it shouldn't be used to deliver care, there's no response. And so I'm going to continue to elevate this uncomfortable piece, that's happening in healthcare. And I'm going to share more if that's okay with Lisa and Mark, because that's my goal. Unless Lisa, do you want to, I can go ahead.
I just wanted to say to that point, when you bring up the fact that we use race and how underrepresented we are in clinical studies for the decisions that are being made for these drugs, on what basis then is that decision being made? I mean, if I'm not represented in that clinical trial, how can you say that's the right drug for me if I'm not in that? So, I'm just curious, that's what I started thinking about.
Right. Well, I'm going to go deeper on that, Lisa. When you look at the study that I'm referring to, it was a small study first and foremost. And then we have to uncouple they associated a specific part of a disease or needing a specific medication based on the sample, the people that were there. But were they African? They just coupled Black and African American and made a decision on the delivery of care. And that byproduct that I mentioned from the kidneys, that creatinine, we know that creatinine can be elevated for multiple reasons. It can be if you have other diseases, diabetes, other factors. If you are under the weather, there's so many different factors. So when they made this decision, not only did they have a small sample, they also had a sample that was not accurate because they grouped people together based on the color of their skin and associated it with an ethnicity, and then didn't take note that that byproduct can be attributed to multiple things, not just based on the color of someone's skin.
That is an amazing point. And if I may piggyback on that, Dr. BCW, and sort of bring us another very real and tangible example. If we all think about our colleagues from school or from church, think about those who either more recently have come to America, literally from the continent of Africa. Think about our brothers and sisters in the Caribbean who have different dietary expectations. And consider if I, for example, being from New York, come to Louisiana and adopt a different diet experience from a colleague a brother, sister who may have been born and raised there, who have a different microbiome or a different cultural expression in terms of how they eat, how they perceive exercise and things. So we are the diaspora of Black people is broad. And what Dr. BCW is really conveying here is that you cannot take this blanket view of just because we're both dark skinned, I may be from an area that has a different cultural expression in terms of the foods I eat and how I live my life. Compared to my brothers and sisters from a different place. And I know some of you, or if not all of us, can certainly think of the colleagues we have at work, look at the differences of all of us. We're a very dynamic race of people and see distinctions even in how we live our daily lives now. So it's a fantastic observation, and we should really internalize what she's saying and feel free to say, you know, do you mean this? And how does this make sense? This is a very safe opportunity for us to talk.
There are a couple of things in the chat. People did begin to share what medications they were on. I see a lot of for products with hydrochlorothiazide attached to them with different things associated with it. One participant, or I should say Berean, as you join these programs, basically is sharing that she has lupus. So her and how it affects her kidneys is very important, the way hypertension, affects this and all. But Carmen, I'm going to come to your question because it's a good one. Do you find that there's a certain race of doctors that prescribe like this, or is this just across the board? I mean, do you find this more with doctors of another race or just across the board? So
it's across the board. There's this old adage of, I'm doing it because that's what I was taught. And that's what I'm supposed to do. And I mentioned in my TED Talk how, and this happened a year and a half ago, where I was in a webinar. And this physician, she's 26, 27, and she was giving a presentation about hypertension. And as she was doing it, she said, the recommendation is to give calcium channel blockers and thiazides for Black patients. So when she said that, I came off mute and I said, I won't say her name. I said, oh, do you mean that was the previous recommendation? And I shared, the studies and everything like that. And she said, no, that's the way it's supposed to be. And I said, well, can you elaborate? Tell me more. Because I always lean into curiosity and finding out where that person is coming from, because I feel like if I can have a discussion and hear them, I might be able to really engage them into learning new things. And she said, well, I just feel it's better for Blacks. And that was a quote. And so I share that story because it shows whether they're in their 20s or in their 70s or 80s, if there's this old adage doing it just because that's the way we do it and not questioning, why are we doing this? And so there are providers of color who are doing this. And sometimes when I've given speeches or when they've seen my Instagram, my little videos, they say, I was always wondering why we did that. And so it's not malice or ill intent. They just didn't understand why. And so it's a mix. And if it's okay, Lisa, I also want to talk about, I want to answer, some people had mentioned that they're on a combo med. And I want to share how the combo meds sometimes can also be detrimental, not saying you can't be on two. And I want to be clear on that. The way it can be detrimental is if you are on one blood pressure medicine that was prescribed based on being Black, and you tell your provider, this isn't working, my blood pressure is still high, or I'm having these side effects, they are more likely to lean into the second class and put that on as an ad in hopes that that will control it. And maybe it will. I'm not saying it won't. However, when you think of all of the other classes that could have been offered that might be a better fit versus combo two medicines based on the color of someone's skin, how it's possible that person could have had better control sooner or had less side effects. So that's something as well, for us to think about.
Oh, So we just need to question, why are you, why are you giving me this medication? Why was this the drug that you chose for me? Those are
Absolutely.
simple, and that's not threatening. That's a
No.
very easy question. Why are you prescribing it? What are you basing it on? I'm curious about the clinical study or the trial that you used to make that decision. And that's why we're having these conversations, so that you feel comfortable and empowered to ask those questions. And if you're not comfortable, find an advocate to go with you on your doctor's visit so that you can feel comfortable speaking up. It's your health, and that's what we want everybody to feel good about. Not just doing something because you're sitting in the office. And I think physicians, the right physicians, clinicians, nurse practitioners, PAs, whoever you may be seeing, will welcome the opportunity to show you that they're making sound medical decisions. If they become defensive, then maybe that's not the right physician or clinician for you. And
I agree. It's a shared decision making. And
yes,
I talk about, especially as a family medicine doctor, I am your advocate. I am your person that I want to know what is important to you. It's not about me. It's about you. And if you're asking me questions about what I'm trying to do for you, that's the right thing to do. And I should lean into that, because in the end, it's about your health and what is important to you. And I was smiling, Lisa, when you talked about, asking your doctor or getting an advocate. I had one person on TikTok reach out and sent me a DM, and it just warmed my heart. She said, I took the study, Dr. BCW, that you put, and I put your video in, and I had a conversation with my doctor, and he said, you're right, I am doing that, and I shouldn't be doing it. And they had a conversation, and so and I've also had people who said the doctor was not willing to change their mind, but still, it gives you armor to be able to go in there and at least ask, because some people are just doing what they were doing before. Some people, they need that little spark. And some may not want to change, but now at least whatever you can have to at least start the conversation.
yes. Okay, I see, Mark, you were answering a question the class in the chat, so there's a reference there. We're coming up on 4 minutes until our conclusion. We try to honor the 7:15 and 45 minutes, so our listeners and conversationalists will come back. We haven't changed it to an hour yet, but maybe that's coming one day. Any questions you want to ask? I may have missed some things in the chat. Please come off mute, ask a question. I know we want to thank Dr. BCW for the time she's given us coming in in the afternoon. We know how busy your schedule is, so thank you. Clay, you came off mute. Anything you want to say? Yes, his hand is raised.
Yes, good evening, Dr. BCW. I just have a quick question about a comment you made recently in your talk, and it was about medications and, high blood pressure medication. Were you saying that a doctor may assign a person, let's say based on ethnicity, multiple medications to control their blood pressure?
No. So what I was saying was, you come in and you're diagnosed with high blood pressure, and then they choose possibly based on your race, one of those two drugs that I mentioned in the class. You come back for your follow-up and your blood pressure isn't controlled, or you're having side effects. They're more likely possibly to pick at the second one from that other class and add it and say, oh, maybe this will bring it down. Versus, what about all of the other the classes that might be a better fit that could control your blood pressure sooner? And so that's my concern about, some people should have, 2, sometimes you have to have 3, but it should be equitable access to all of them versus a specific group only really going after the first two classes versus if those that are not Black, there's a whole choice of, classes that provider is looking at, and then adding from all of those too. I hope that helps.
Yes, it does. Thank you.
This is the silent pause, giving you a chance to ask questions.
Dr. Bayo, Curry-Winchell, can you briefly talk about the different classes? I know that's a lot to ask for layman terms, but just so that we're aware of what we should ask.
Absolutely. So there's two classes. So the first one is a thiazide. And again, that's a very general term that has multiple drugs underneath it. And it's important to know that there's generic drugs and trade name drugs, but always look at the class. You could always Google what class does this medication belong to? And so the two classes are the thiazides as well as the calcium channel blockers. And so there's a lot. So I'm not able to name them all by heart. I probably could have when I was in residency, but there's several. And so if you take that medicine, whatever your whatever one you're the one that you would like to know more about, and then write in the Google, what class does it fall under? You'll be able to see it. And so those are the two types or classes that are recommended based on Black patients. And you'll see this in different credible resources, such as UpToDate. All of these tools that clinicians use to this day, you'll see them still, it still reports it. And so it hasn't been taken out of practice, unfortunately. And I'll give you also some more information. There was a recent study by the National Institute of Health that showed even when there's new evidence, it takes about 17 years for new evidence to translate into standard clinical practice. And so when you think about that, and this one hasn't even really been changed yet, how long it's going to take, even when there's more push behind it. Now, for the GFR, there was an article in the USA Today a couple of months ago that recognized this, and they're asking labs to no longer differentiate Black versus non-Black, which is great news. But the problem is, I've got multiple things that I'm concerned about. What are we doing for those patients, those Black patients that have been assigned the wrong class of kidney disease? So yes, moving forward, we hope that's no longer will affect patients of color, but what are we going to do for those patients that have been diagnosed incorrectly? And 5-10 years from now, we'll find out that they have advanced kidney disease. And then also, what are we doing to really infuse this new information that is affecting lives right now every day? So yes, it's great to say we're going to remove these, but what education, what pieces are you going to put forward to make sure when someone's in a clinic that provider still doesn't think, oh, their kidneys are healthier because of their race?
Mm-hmm. Mm-hmm. Quick question and follow-up to Michelle's question. I know that there are more classes of drugs to treat hypertension. If we wanted to come to a physician and say, outside of the calcium channel blockers or the thiazides, what other drugs might you recommend? Where should we go? I know it's a lot. How should we approach having that conversation about a different class of hypertensive medication?
So that's when you're going to really be able to, and I can put some links in the chat, look at, there's one called Hippocrates, where you can see all of the classes. And it's important that I mention those two classes might work for you as a Black patient. But when I say as a Black patient, It's just because as a patient, it has nothing to do with your color of your skin. It just might work for you. So that's
Right.
important, that you don't necessarily have to avoid it. My ask is show them all of the types and also be willing to use all of the medicines, not just those two. I hope that part is helpful because it might work, but that's just because of you as an individual. Has nothing to do with the color of your skin. And maybe when we uncouple this grouping of race and ethnicity inside in clinical trials, we might discover, yes, certain medicines might work better for certain ethnicities. But until we uncouple that, we can't group treatments based on my skin tone.
Right. Yep. Very good. Any additional questions? There's time. Go
Just
ahead,
one
Michelle.
one more question. Tonight, we're focusing on hypertension, but should we also be aware that this race-based treatment is also prevalent with other illnesses?
Yes, and there are several. I can share one more. Do we have time? I don't want to go over, Lisa. Is it?
I think those who are willing to stay are going to stay if you are, so go for it.
Okay, yeah, I have until 4:30. I'm on Pacific Standard Time, so I've got about 8 more minutes. I will share this one, and this one is near and dear to my heart. So we know right now that Black women are dying 3 to 1 in childbirth, correct? We keep hearing about it versus white women. And then I always lean into curiosity and I think, well, why are Black women dying? And we often hear the access or more doulas are important, and they are. That's not what I'm saying. But then I look at if it's a risk of death during pregnancy, and the US has such a robust healthcare system, there's more to it. And so there is a score called the VBAC score, or vaginal birth after C-section. So back in the day, around from the 1990s, I think it was till 2007, the old adage was when you had a C-section, you always needed to have a C-section because of the complications that were associated with trying to give birth after you had a C-section. So a lot of doctors were like, oh, we just want you to have a C-section because it's too risky. Well, we know as scientists, as physicians, that having a natural birth is the best. Speed, faster recovery, less complications, all of those things. And so the government decided, what can we do or give a system that can help doctors lead their patients into trying or feel comfortable letting their patient have a vaginal birth after a C-section. So this score was supposed to help doctors, allow women to have more. So in this scoring system, there were 4 questions. One was age, because older women may have more complications. Height, because the bone structure of more petite women might not allow a bigger baby to pass through. Weight, because heavier women might have more complications. Well, the last question that is asked in the scoring system is the patient African American, Black, or Hispanic? The scoring system disregarded all other races and ethnicities. So I want everybody to imagine that you've got 2 women with the same age, height, and weight, and with equal risk. One will get to choose natural birth, and the other will go into a C-section solely based on the color of her skin. And so when you look at this scoring system, and then you think about Black women being pushed towards a C-section and not having the chance based on the color of their skin. Oh, is someone? Oh, I thought I heard someone. To have a natural birth, that is a piece that is detrimental. So this scoring system was just removed in 2021. However, I shared with you that scoring, that study that it said it takes 17 years for new evidence to translate. I'm also going to sprinkle in something even deeper. When the scoring system was released, multiple studies found doctors were performing mental calculations of the scoring system in their head of
Mhm.
making a decision if that woman was going to have a vaginal or a C-section. So even if you remove this scoring system, which was removed in 2021, it is still pushing African American, Black, and Hispanic women towards a procedure that carries a higher rate of death. And so I hope by sharing that algorithm or that race-based practice helps you kind of think every time you hear Black women are dying in childbirth, think of that scoring system and how they decided to include those three groups as not likely to be successful to give birth. And I go back into my anatomy is exactly the same as someone who's not Black. So why would I not be able to have a vaginal birth like somebody else?
Mm.
I hope I explained that well.
You did. Very clear. We need to take a moment, think about how race is not biological or genetic, and that bodies are created the same, and the choices for how treatments are being handed out to us, we need to rethink what they are. It isn't, I liked the clarification you made with calcium channel blocker may work, thiazides may work, but please offer me a buffet and not just a single plate, and let me go to multiple places to figure out the treatment. And thank you for that opportunity to open our thinking, empower us, remove the barrier of fear, and provide us with greater real access to care, not the access that we're talking about. I love how you differentiate what access is and what we're talking about. So this, we hope, will not be the last time that you would consider joining us for other topics. We can monopolize your life. We would love this one-on-one care. So thank you for what you shared with us today, Dr. BCW. Next month, we are speaking to Alzheimer's and how it impacts and affects the Black community. So we definitely are going to take a look at a couple of videos that way. And I'm going to go to your site and see if you have anything on Alzheimer's that I should reference and take a look at for the next time. Okay. Thank you, everyone. Have a great night. We appreciate your joining us. You could have done anything else, and be on the lookout for a survey. Bye-bye. Thank you.
Goodbye.
Okay.
Have a blessed night, everyone.
Okay.
Thank you, Dr. BCW.
Thank you. And follow me on Instagram or TikTok if you want. It's all free
Yes.
information.
I will be looking on TikTok.
Perfect. Dr._BCW.
Thank you.
All right. Bye.
Bye. Have a good evening.